My name is Ash, and welcome to Paved with Gold, the Eating Disorder Recovery Podcast. I want to acknowledge the traditional landowners on which I am recording, the Gadigal people of the Eora Nation. As you will know from the title of this episode, today we are going to be talking about ARFID, which is Avoidant and Restrictive Food Intake Disorder. And I know that we've said on this podcast before that we tend not to really talk about eating disorders individually, such as anorexia, bulimia, binge eating disorder, etc., as separate disorders, but we tend to focus more on eating disorders as a whole, because I think that all eating disorders and disordered eating are as dangerous and as serious as each other. And I really don't like how oftentimes eating disorders are pitted against each other, often as more serious or not as bad, or there's stigma for one over another. And at the end of the day, the symptoms or behaviors are less significant than the overall mental and physical toll that they take on one's life. Having said that, I wanted to take a closer look at ARFID today, not because I want to single it out in any way, but because there is a lot of discussion around it. Some saying it's not as serious as, other eating disorders, and it's just people being picky eaters or being fussy. Spoilers, it's not, as we will get into. I wanted to talk about how ARFID can be common. Well, it can be common amongst children, but equally amongst adults, and it's something that shouldn't be dismissed as, oh, my child's just being fussy. But we're going to take a look at how ARFID is also very common among people who are neurodivergent. And there's still a lot of people who don't know about this disorder, myself included. So I wanted to put a spotlight on it today. And to help me do that, I have invited a wonderful guest. My guest today is an accredited clinical nutritionist. She is proudly neurodivergent and is a mum of two. She has a lived experience and uses this to provide neuroaffirming and trauma-informed care as the founder of Whole Body Nutrition. It is my absolute pleasure to have Margo White join me today. Welcome.
Thank you so much. I'm very excited to be here and talk all things ARFID.
So we always start out this podcast, when the situation warrants it, talking about someone's lived experience. So we'd love to know, what is your story? Where did your eating disorder start? Where did it come from? And what does it look like today?
Yeah, sure. I'd love to share that because I actually haven't really shared it in great detail. Obviously, I won't go into everything, but I haven't shared it really much before in detail. So I'm going to, go back to the beginning essentially. And I feel like you've probably heard this before, but it all started with dance, specifically ballet. Yeah.
Oh my goodness. Okay. That is another separate episode I want to do, is all of that kind of stuff, but I won't get ahead of myself. Continue.
Yeah. So I think I was in grade 1 at the time, and, I wanted to be a ballerina. I don't know where it came from. I just did. And, I remember essentially being in class and looking around the room and just noticing all the different bodies and feeling like I looked different. I was tall. I've always been really tall for who I am, for who I am. I'm 6'2" now.
Oh my goodness.
But, yeah.
Okay. I'm 5'11" or so.
Yeah.
Okay.
That's
I'm always
pretty
used to
tall
being
too.
I'm always used to being the tallest one, but then 6'2". Wow. I feel your pain.
Yeah. And people are always
finding pants is so hard.
Oh my gosh, don't even get me started. And then also the comments, I digress, but the comments of you're so big, you're so tall. Can you see the weather up there? Do you play netball? Are you a model? Do you play basketball? The questions are relentless.
Oh, it's almost like when you get congratulated for being tall, it's
I know.
I didn't do anything. I really did not do anything.
Yeah, totally. So yeah, looking around the room, I was taller, I was bigger than the other kids. And essentially, I guess that's where the first thoughts started to come in. But then I was due to take my first ballet exam. And, from my perspective, I'd worked really hard to try and to get through that. And when I had finished, I thought, I felt proud of myself. I thought I'd done a good job. Unfortunately, I actually failed the exam. And the really awful thing about it was that my teacher told me that it was because my body type did not resemble that of a ballerina. And so you can just imagine a little, what would I have been, 6 or 7-year-old being completely shamed and embarrassed for the way that they looked when, dance and ballet is supposed to be fun.
And it's about expression and being creative.
Exactly.
And Also hard work. And like you obviously had probably worked really hard for it.
Yeah.
And then it's just been like, no, your body's wrong. It's
Yeah.
like, okay.
Exactly. So that was like the first message, I guess, that I got. And, of course, I quit ballet. I was like, well, I'm not doing this anymore. But I did continue doing jazz, and I did that for a few kind of like more years. Around the same time, I was also being bullied at school. I was called names, I was teased, etc. And
I got called Gigantor.
Yeah,
because of my height as well. So it's like, thanks, guys.
Yeah, yep. And the school environment didn't help because, I'm not sure exactly what they do now, but back then we used to be weighed and measured at times. Yeah, like only a couple of times for like a science experiment, but all this stuff, it all contributes. Anyway, so I learned very early on that my body did not feel safe, that, the way I looked, the way I felt because of these comments and all of that meant pain essentially, and rejection and
trauma.
And trauma, yeah. And I think, I'm sure I'm not alone in this. I feel like it's very sad because we don't come into the world with these views. We don't even necessarily think about our body in any way. And then we learn these things from diet culture, from people making comments,
or taught.
We're taught. Yeah, 100%. Yeah.
Yeah.
So essentially, I just had very low self-esteem. I had poor body image for a very long time. But it wasn't actually until I would say year 9 that I developed anorexia. And, at the time there was a lot of stuff happening in my life, a lot of pressures coming from different places. I had stuff going on with friendship groups. I obviously didn't realize at the time I was neurodivergent, had no idea. And, my parents as well, a few years earlier, had divorced, and so my family was separated. So I went and lived with my mum, my siblings went and lived with my dad, and there was just a lot going on. And I was essentially looking for something to create safety, to distract me from the pain, to gain back some control, essentially. And really, my eating disorder became a lifeline in a lot of ways. It gave me something to focus on, gave me a routine. And this helped me to create emotional safety. However, obviously, eating disorders are not good. And it also brought up a lot of trauma, and there was a lot of negative stuff that obviously happened. So I started dancing again. Funny because it's kind of like a full circle.
Yeah.
And at the time, I had started restricting food. And I do remember specifically thinking, like, I want to lose weight. I thought that if I had, it would make everything better. And, people started noticing, started getting comments, boys started showing interest. But not all the comments were good either. Like, people were worried, but the way that they approached the comments just made me feel so ashamed and embarrassed. Yeah. So the next sort of thing that happened was my mum actually ended up taking me to see a GP. And at the time, I was very much in denial, and I was like, oh, I'm just dancing a lot. And, I didn't realize I needed to eat more or whatever. But the GP told me that I had to gain weight and that I should take Sustagen. And, at the time I actually had lost my period. So that was something that I was concerned about. So I thought about it, and I was like, okay, I will gain a bit of weight back. I will take this Sustagen. And so I did. I gained a little bit of weight to what the doctor essentially thought was acceptable. And went back to the doctor. The doctor was happy with that, and nothing was ever said again. So I walked away maybe being at a more acceptable weight, but still underweight. And so my body was maybe a bit more nourished, but not nourished enough. But my mental health, my relationship with food, was not addressed for another maybe 20 years.
Oh, wow. Okay.
Yeah. So I essentially lived with food anxiety, trauma, health anxiety, like low self-esteem, poor body image, like you name it, for the odd 20 years. And I would say the anorexia morphed, and I was able to kind of nourish my body enough. But I would also say that it morphed into orthorexia, particularly around the time that I had my kids and then was also studying at uni. So studying to become a nutritionist. And, you know, a lot of the stuff that we're taught is incredibly diet culture driven and healthism driven. And that was actually really detrimental to me for quite a while.
I can imagine.
Yeah. So then I went through my ADHD. So I'm autistic, ADHD a couple of years ago. And it was like a light bulb went off where this really helped me to see the relationship between neurodivergence and my eating disorder. And it was like all these missing pieces kind of came together, and I could see how the trauma had led to like the eating disorder and everything. And that was like incredibly life-changing, and it completely redirected my business in the most amazing way. And so like now I support other ADHD or neurodivergent folk that have also lived experience or are going through different eating disorders. And one of the key areas that I work in is ARFID. And although I don't have ARFID myself, similar to what you said earlier, like I feel like all lived experience is really valuable, and I feel like I really can relate to a lot of people with different eating disorders because I have been through one myself, and I'm also neurodivergent. So I just get it.
Yeah. I don't think you need to have, you would need to, it's not necessary for you to have experienced ARFID to not understand exactly why it happens. You know what I mean?
Yes.
Because I think if you are saying, I think this is with a lot of neurodivergent folk, is that your brain is just kind of operating on a different system.
Yeah.
And you're feeling completely out of place in a world that doesn't really feel made for you at all. But then if you can relate to that on some level and then say, I don't ask myself why you're doing this. I ask myself why not.
Yes.
You know, like, of course, this makes sense that this is happening, you know?
Totally. And essentially with any eating disorder, and we'll talk more about ARFID and trauma shortly, but with any eating disorder, realistically, it stems from trauma. So if you understand trauma and that, then you're going to understand someone else's experience, you know, especially if you've been through that and it's led to you having an eating disorder.
100%. I think there has been talking on this podcast with a lot of people, a lot of different people, a lot of people sharing their experience. Trauma has been almost a unifying factor with a lot of people. If it's not trauma that has led to the eating disorder, they've experienced trauma themselves with the eating disorder, whether that's medical like trauma from treatment as well.
Yes.
That can exacerbate eating disorders. And so trauma seems to be a very, very common thread, which I think the fact that trauma-informed care is not a absolute bare minimum requirement must have for any person treating eating disorders is still astonishing to me.
Blows my mind.
But I think we're slowly moving in the right direction. I think everyone is saying, no, we totally need more trauma-informed practices. I'm glad we all agree. Now let's do it.
Yeah. Let's put it into action. Let's like incorporate into studying, and absolutely agree. So important.
Just a side note. I see so many similarities in your story and mine. I like being tall, being like come from separated families, bullying at school, all of that kind of stuff. And I'm just like, yep, tick, 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 tick. I fully get you. I'm also currently in the process of, I've got an appointment in 2 weeks for potentially an ADHD diagnosis, seeking that out because it would make a lot of sense.
Yes. Yes.
And so that's, again, all of these things I'm like, yep, I relate to a lot of what you're talking about. Also, I did gym as a child and I was told I was too tall to continue. And they're like, well, you can't really do gym or like you won't really get very far because you're too tall. I'm like, thanks.
It's ridiculous.
I'm like 10.
Yeah, I just want to do this for fun. And like I just think it's just ridiculous. It's really, really sad. And also like just going back to my ballet teacher, I actually adored my ballet teacher. I like looked up to her and thought she was the most beautiful person in the whole wide world. But as an adult now reflecting, and I'm like, she should never, ever have relayed that information back. That she could have said so many different things, which could have, she actually did say to me the reason, but then she said, but I still think you should keep doing ballet. So she wanted me to continue, but it's just like, it's too late.
Yeah.
Like,
it's kind of already spoiled.
Yeah, exactly. And also I was just going to say with like getting that diagnosis, I think a lot of us that are late diagnosed, we do live our life thinking there's something wrong with us, or we're different, or we don't quite understand why we don't quite fit in, or why things are harder for us or feel harder for us. And so when you do get that diagnosis, 100%, there can be lots of different feelings and emotions that come up. But for me, from my personal experience, it was incredibly validating, and it just really helped my life make sense. And it helped me to stop blaming myself essentially for the things that have happened in my life, and to just really, have compassion for myself. Yeah.
So I think let's get into it, shall we? So can you please tell us what is ARFID and what does it look like? Although I know that it can look like many different things, but what are some of the things that can help us understand what ARFID means and is?
Sure. So to begin with, ARFID was only recognised as an eating disorder in the DSM-V in 2013. So we know people have had ARFID for much longer than that, but it's only just been recognised, which does unfortunately mean that a lot of providers, carers, don't know a lot about ARFID, and we're still learning about this space as well. So ARFID is a mental health diagnosis. It's a multi-faced eating disorder and a neurodivergence characterized by severe food avoidance or restriction. And people of all sizes, ages, and genders can have ARFID. So I view ARFID as a neurodivergence because it's not something that you can like quote unquote cure or fix. It's not something that just goes away as someone ages. But if you can find the tools and make the accommodations to support ARFID, it can really help someone. So depending on someone's capacity, their circumstances, their trauma, the dynamics of ARFID can shift and change and fluctuate throughout life. Essentially, ARFID can originate from anxiety, fear of food or eating, past trauma, sensory processing differences, and that might involve taste, texture, or the smell, or even the visual aspect of food, from society, cultural norms. So also coming in like the judgments from others and the shame that people can feel for the way that they eat and the way they choose to nourish their body. And then also just variations in executive functioning. So with ARFID, it is often not related to fear of weight gain, although there can be co-occurring body image concerns, anorexia can co-occur, and eating disorder behaviours. So even though in the DSM it does say it's not related to fear of weight gain or body image, for a lot of people there can be body image concerns there, and we don't want to just rule ARFID out because someone also has body image concerns. Also, it can co-occur with individuals that are autistic, that have generalized anxiety, ADHD, OCD, and many, many more. And the kind of estimated percentage of autistic people that have ARFID is around 20%. So 20% of people with ARFID will also be autistic. Essentially, there's 3 different subtypes of ARFID according to the DSM. So I might just go through them like kind of briefly because I think it can be really helpful, for people to unpack. But so people can fall under 1, 2, or all 3 of these subtypes. So there's avoidant, restrictive, or aversive. So avoidant is where food is limited due to those sensory differences. So there might be a particular hypersensitivity to taste, textures, and the visual aspect of food. And this can often kind of like co-occur with the autistic side as well. Restriction. So restrictive is typically exhibited by little interest in food or eating. It could be due to low appetite, or challenges with interoceptive awareness. And people might like forget to eat or become easily distracted. Like they may hyperfixate on something that they love doing and not eat all day or not eat for hours. So that's kind of typical of restrictive. And then aversive is where food is restricted due to a trauma or a fear-based experience. So we might see that perhaps there was force feeding as a child, or they entered into feeding therapy, or there may be like a fear of vomiting, nausea, choking, or someone may have had like an allergic reaction. And I think from my perspective, I see like a lot of ARFID folk, and I'm yet to meet anyone that does not have this aversion trauma element. And it can even, like it can even be as simple as I've had quite a few clients who are young children now who, when they were babies, they were born and they had a tongue or a lip tie and they had to have that cut. And even something like that, where they may not remember that, but the body stores the trauma. It's something to do with the mouth, which can impact eating. And so, that can develop into ARFID. And as I said, like I'm yet to meet anyone that doesn't have that trauma element. Like it's massive. And that's why trauma-informed care is so important in ARFID support.
Yeah, it's really interesting to hear you say that trauma in this sense isn't just mental. It can be a physical response from the body of remembering how of something that happened physically. That's really interesting.
I really, really believe that that's true. Like I've had quite a few clients that, that do remember specific situations where, a parent or a carer has force-fed them. But then also people who have told me stories of, where they know that there's trauma stored in the body. They don't quite know where it's come from. But then when we unpack the different sort of things that have happened for them when they were very little, it often will, implicate or, indicate ARFID.
I actually think, because I follow you on Instagram, and I think everyone should, and all the links will be in the show notes below of where to find you. But I think one graphic that you put up was so interesting in terms of it really made it got people to really understand, got me to really understand how understandable it can be, especially for people who have this need for things to be the same and consistent in terms of not being experiencing sensory overload and things like that. There was your graphic where it had all these different apples, all the same color. It was like 5 red apples, and it was cloudy, crunchy, sweet, sour, or flowery.
Yes.
And then on the bottom, it was a bunch of beige crackers that all look the same.
Yes, like predictable, reliable.
Like yeah, all of that kind of stuff. They all have the same consistency, the same flavor, the same amount, and that is just can be really comforting for people of why you were talking about safe and unsafe foods and those kind of things. Can you talk a little bit more about this idea of safe and unsafe foods and why you see a little bit more of like predictability and why it's not just fussy eating?
Yeah, so ARFID is 100% not just picky eating or fussy eating. Like if we're talking about the sensory element and the trauma element involved, let's just say, so with anything that is viewed as a neurodivergence, I really believe that capacity can change daily. So for someone, let's just say that there is overwhelm going on, the nervous system's distressed, maybe there's something that's happened at school or at home. Even as autistic, neurodivergent people, we always have a low lying kind of level of anxiety there anyway. But let's just say in terms of our capacity being low, if we have trauma with food or sensory aversions to food and we're feeling dysregulated or distressed, we can't enter into eating something that would further distress us. And we often see with people that have ARFID that rather than eating for comfort, like a lot of people do, after a hard day of work, whatever, we'll come home, we'll eat some chocolate, we'll have wine, whatever people enjoy doing, they do that for comfort. Whereas with ARFID folk, we avoid food they'll avoid food for comfort and safety.
Mm.
So it's part of when something causes you immense anxiety and stress, you're not going to engage in it unless it is predictable and feels safe. So safe food essentially is a food that helps to keep someone regulated, that is predictable. They know what it's going to taste like. They know how it's going to feel in their mouth. And there's no associated anxiety or very little associated anxiety with eating that food. Versus, say, entering into eating something, anything, and that further dysregulating you struggling to eat it, maybe choking or gagging or whatnot. And then also, when we talk about the nervous system, if we're in a state of fight or flight, we're not going to be able to digest and absorb that food as well as if we were in a state of like rest and digest. And so if we were to engage in eating something that's going to further distress us, we may also then end up having, IBS symptoms or bloating or other things come up, which then it's like a negative cycle. It's like,
that would totally be distressing too.
Yeah, it's distressing.
I know when I feel bloated, I get so much more anxious because I'm just like, I feel so uncomfortable.
Exactly. Yeah. And then that can be really, really off-putting towards foods as well. Mm-hmm. We don't want to eat if we're feeling nauseous or bloated, or highly anxious. So it's, I hope that all makes sense and answered the question.
Yeah, it totally does. I think there's also some confusion about, especially when you're looking at ARFID, or what we know now as ARFID, or just picky eating, quote unquote, even though it's not, in children, the difference between ARFID and a feeding disorder. Because I think I asked you this, I emailed you this question, you wanted to clarify in terms of pediatric feeding disorder. So what is the difference there?
Yeah, so pediatric feeding disorder is essentially a multidisciplinary diagnosis that includes feeding dysfunction in any one of these categories. So medical, nutrition, feeding skill, or psychosocial. So it will only occur in infants and young children between the ages of 0 to 6 years, and it focuses on the inability to eat age or developmentally appropriate food to obtain nutrition that's needed to grow, essentially. Whereas, ARFID and all other eating disorders can occur at any age, essentially. Like ARFID, if you essentially you may not, how can I word this? ARFID may not be present when you're a child, or it may be present, but you may not realize rather that you have ARFID. So you might not be until you're an adult that you actually realize, what I was experiencing what I was experiencing when I was a child was not actually picky eating, quote unquote picky eating. I actually had ARFID. But the fact is that it can occur at any time of the life. So whereas pediatric feeding disorder, so breaking it down, essentially it involves challenges with the physical process of eating. So we might think about like oral motor difficulties. Sometimes sensory sensitivities can come into it, or medical conditions that impact eating and make eating uncomfortable. And essentially, it's the child is not able to consume sufficient nutrition to grow and develop, at a rate that they should be. So eating disorders and ARFID are more categorized as mental health conditions that involve a really difficult relationship with food, eating, the body, trauma around food, and they're more driven by that psychological and emotional factors and desire for that safety, and sometimes comfort, fear of weight gain and comfort, and exactly. Yeah, so they are different.
Yeah, totally. And I think based on what you were saying before, I mean, could you say, in your opinion, or in both a personal or professional opinion, could you say that perhaps being diagnosed with a feeding disorder as a child could potentially make you high risk for ARFID later, given what you were saying about like a physiological trauma response, perhaps?
I do think so. Yeah, I do. And I have had some clients, I actually do have a few clients that I see that they come to me for ARFID support, and they're sometimes even given, it's kind of hard to explain, but they're kind of given the pediatric feeding disorder label versus ARFID because the other practitioner believes that will be more valid or more better supported or something. And maybe what that comes down to is the fact that ARFID is still being learned about by a lot of people. But yes, to answer your question, I do think that it could lead to ARFID, especially if, and I know we'll unpack this a little bit more, but especially if they are neurodivergent. Yeah.
Yeah. Yeah, I think it's, we're not saying that, you will definitely develop ARFID. It's more, we always say people who are high risk and engaging in harm reduction and things like that, or just being more aware that this could potentially be something to consider and knowing warning signs to look out for it so that you can be there to support later if it does happen.
Yeah, exactly.
But yes, you mentioned neurodiversity, so let's open the door to it. Yep. I think, I know we've talked about who's most prone to developing ARFID, but why do you reckon ARFID is more common in neurodiverse folk?
Yeah, so I do think there's like a few different factors, but essentially one of the biggest ones is that sensory processing differences. So, for example, autistic and ADHD folk can experience a heightened sensitivity to sensory input, and this can, really impact the way that we taste food, the texture of food, the smell, the appearance of food, as I've already mentioned a few times. So this can make certain foods really, really overwhelming, and even for some people, like painful to consume. So so it's really that I would say that is one of the main things, and then interoception comes into it as well. So we know that for neurodivergent people, we can often struggle with interoceptive awareness and have different ways that we might get those internal body signals, and everyone experiences their internal experience differently to other people. So it's not all felt the same way. For example, we don't all feel hunger the same way. We don't all feel the need to go to the toilet the same way. It can be different for everyone. So in case people listening don't know what interoception is, essentially,
my next question.
Yeah, essentially it's the ability to sense and interpret internal body signals. So this might be feeling hungry. So the body telling the brain, you're hungry, you're thirsty, you need to pass a bowel movement, you need to urinate, you're feeling hot, you're feeling cold. So we might, we would typically hear that, most people would feel hungry via a grumbling or a empty tummy. But for a lot of neurodivergent folk, they might feel hunger as this hangriness that comes up. So feeling really moody out of the blue. We might get a headache. We might have a dry throat. Like, it's very different for everyone, but it is really important to understand what your signals are, so that you can support yourself with your eating and other things. And yeah, look, that can be tough sometimes. So it is helpful to work with someone. But so essentially, interoception is also one of the key parts of ARFID, as I mentioned previously. And so in the restrictive subtype, the interoceptive awareness and the difficulty with seeing those and feeling those cues can really impact our eating as well. And then also I think the heightened kind of anxiety that can occur in neurodivergent people simply for, existing in a world that was built for neurotypical people, essentially. So we can have an increased level of anxiety around eating. We might have an increased level of fear around choking or like bringing up food. And this can make eating stressful, like it can make it a stressful experience. So it's very valid and normal for a lot of neurodivergent people to have a challenging relationship with food. And I think it's really valid to acknowledge that, because I feel like we're often told messages that there are right, I'm going on a tangent, but that there are right and wrong ways to to eat when there aren't, everyone's different.
Leads perfectly into what I was going to say next, which is I think a lot of this new approach in terms of wanting to move towards an intuitive eating kind of plan, those kind of things, it can, and I know Callie's very passionate about this, is that a lot of people who are neurodivergent don't have that intuition
Exactly.
of when to eat. They don't have those hunger cues. But of course, then it's like, okay, well, what does intuitive mean for you? And that's absolutely true. Like I know that she is, and I'm definitely a little bit more, I'm much more of a snacker and those kind of things in terms of I'll have, maybe 5 small things throughout the day rather than 3 big meals. And when you go into eating disorder treatment, particularly, it's you have to follow this meal plan at this time, and then
it's very rigid.
It's very rigid, but also people then think, especially if you're neurodivergent, that that's how you have to eat for the rest of your life.
Yes.
And it's kind of blurring these lines of, well, you can't trust your intuition or you don't have that intuition. And it just can get really, really confusing. So it makes perfect sense why you say, okay, well, why don't I control my eating in the exact way that I know how?
Exactly. Yeah, totally. And it's so valid that not everyone can eat 3 meals a day. So it's totally fine if you can get enough food in via eating 5 snacks a day or whatever it is that you need to do. At the end of the day, like we just want people to be fed. Like that is the most important thing. Fed is best. And whatever gets the nutrients in, like that's what's important, not how you eat or where you eat or, that sort of stuff.
Absolutely. This wasn't on my list of questions, so forgive me for the blindsiding you. But I think you just talking about this, the best thing is fed is best. What are some of the potential risk factors that people might not know about or some that they might know about in terms of, like, what are the dangers of ARFID? What are some of the risks that can occur with ARFID?
Yeah, definitely. So
that's a very long-winded way to explain that question.
Yeah, I understand you. Look, definitely there can be nutritional deficiencies, absolutely. And so it is important to kind of work with someone and assess those and, if need be, support them. But not everyone with ARFID will have nutritional deficiencies. Some people will be able to get exactly what they need from what they're eating, so from their safe foods. But if there is nutritional deficiencies, so in my clinic, we'll typically I'll either do blood tests or I'll do a hair tissue mineral analysis. So with regards to bloods, that can be really difficult as well for a lot of people and anxiety provoking. So when that's not an option, a hair tissue mineral analysis can be a really good way to get some information around the mineral excesses or deficiencies and just generally how...
Are you trying to tell me that you're trauma informed?
Yeah.
Is that weird? Take notes, people. This is what we're talking about when we say trauma informed. It's like, oh, a blood's going to be too stressful. How about this as an option?
Yeah.
Bravo.
Yeah, exactly. And like, I'm also kind of like, if neither of those things are an option, we can totally still figure out what, just through thorough questioning, like what might be deficient, what they might need to just kind of cover all bases. And this kind of leads me to say as well that it is so valid that we sometimes can't get everything we need from food. And so it is absolutely okay and valid to take supplements if you need them to bridge those gaps. There should be no shame around that. A lot of ARFID folk will need nutrition drinks. Not all, of course, but there's absolutely no shame in needing that. Whatever gets those nutrients in is what is important.
Yeah, especially when there's certain only specific foods that can deliver certain nutrients.
Yeah.
You know what I mean? Like there are certain that you can only get a certain vitamin from this food or these types of foods. And if you don't like any of those, or it's not easy to incorporate them into your diet, then what do you do?
Yeah, exactly. Yeah.
So that's where supplementation can really be helpful.
Yeah, exactly. And I think too, when we're talking about ARFID, if a child or an adult doesn't have a support system around them, and I'm talking about like several people, not just one practitioner, but several different practitioners and family or friends or whatever that are really dedicated to providing that neuroaffirming, trauma-informed support for that person. It can be just really, really tough, because if they're not feeling safe and supported in their eating, then we will see capacity drop and we will see foods drop. And that is when things can get scary, because when someone's only got a couple of safe foods, or they're not eating enough, or they're not eating regularly, like that is when there is a lot of concern. And so, yeah, I guess I'm kind of just saying the same thing, but it just shows how absolutely important it is to make space for people and not to force any tasting of food or food exposures or anything like that as well.
Yeah.
Yeah.
I think some people might think that it's not as serious as other eating disorders, which isn't true either.
Yeah.
Because there can be some serious dangers with ARFID. And also it's not just with nutritional deficiencies, but also anxiety provoking,
Totally.
Because I think it's clearly experiencing quite an anxious thing to be forced to eat something that your body is physically rejecting.
Yeah.
Whether that be mentally or physically.
Exactly. And if someone is avoiding a food, it's because it doesn't feel safe to them. Like, we shouldn't, like children particularly, but adults as well. And I know we touched on this before, but are often labeled, and it's a negative label. It's meant as a negative label, as, picky or fussy eaters. The reality is that if someone is not eating a food, it's because it doesn't feel safe for them, and because they're trying to meet their sensory food needs. There's kids kids and adults shouldn't be shamed for trying to meet their sensory needs, but these labels really can cause a lot of trauma and internalized shame for a lot of people. So it is important to think before you call someone a picky eater.
Yeah. You segue us very, very perfectly, because the question I wanted to ask is, there could be people listening to this who are saying, oh yeah, well, my child's really picky. But they might be questioning, okay, is my child picky, or is there something else there? What are some of the key differences, and what can people sort of look out for in terms of, is my child just being fussy? Because, hey, kids can be fussy.
Yeah.
That's just the nature
and
of exploring food.
Out of that.
Totally. But what are some of the key signs to look for when it could be indicating something else?
Yeah, so I think that if it's indicating something else, there'll be a lot of anxiety around food. There might be meltdowns. They'll avoid wanting to eat with other people. Maybe they'll avoid wanting to eat at the table or to have meals with family. And I would say that if they're neurodivergent and they are incredibly selective with what they eat, then it probably is worth just having a conversation with someone that understands ARFID to just gauge whether this is like a normal developmental, sorry, I don't like the word normal, but like a developmental,
I know what you mean.
Developmentally appropriate kind of response to food and eating, or whether there is something else going on that needs extra support. Because if it is ARFID and there is that anxiety, that trauma response, we will most likely make it worse if we push food on them. So I think it is worth investigating a bit more if they're neurodivergent as well. Yeah. Or you see any of those other kind of flags, essentially.
Yeah. And it's also noticing a pattern of things, right?
Yeah.
I think, which is, I just, the last episode that I did was about, if you think someone has an eating disorder, what are some of the key warning signs, and how you can approach it with them? It's not, it's just a one-off thing, because some people don't eat the same way every day.
Totally.
But if you're noticing a pattern of things, especially with your child, a pattern of meal times are always a struggle, there's always meltdowns, there's constant anxiety.
Yeah.
That is where there should be sort of greater conversations.
Yep, exactly. And another kind of key might be that there might be something really stressful going on for that person, maybe at school, or something unsettling's happening at home. So, yeah.
100%.
Yeah.
And I think that that also comes with, granted, I'm not a parent, so I will never pretend to know, but this also moved towards gentle parenting, whereas it's more understanding the needs of the child and connecting on an emotional level, those kind of things, and really understanding if there is meltdowns or there's tantrums, trying to understand where it's coming from.
Yes.
Which I think can be really helpful here, as opposed to you're not getting up from the table unless you finish your plate, or you're not getting up until you finish that, or you're punishing people because they don't want to have food that is causing a massive anxious response from them.
Yeah, totally. Yep. And I think, as adults as well, like if we don't want to eat something, we generally, we won't eat it. Like, so kids should also be allowed that same, support as well.
Absolutely.
Yeah.
I'm hard in the camp of I despise avocados. I know that makes me weird, apparently. But yeah, it's just, like, people have their dislikes, people have their likes, all that kind of stuff. Some dislike things for different reasons.
Yeah.
It should never be, I think a child not wanting to eat something should never be discarded as being fussy.
Yeah.
But also look at the behaviors around why they're not eating something, which is, I think, the sort of what you're saying is look at the bigger picture here.
Yeah, exactly.
Nuance, individualize. It's all different.
Yeah, exactly. That's right. Yeah.
So I think what you were saying, which is at the start, which was really important, unlike other eating disorders where they can be treated and cured, quote unquote, cured sometimes.
Yep.
Although a lot of times it's managed, or recovery is an ongoing thing. Again, all nuance. We could get that's. I've talked on that multiple times in other episodes. But unlike that, ARFID, oftentimes there is no cure, and it has to be managed and just treated. Those kind of things. So much like I think neurodivergence can't be cured, because it's just the way that people's brains operate, right? What are some tips to help people navigate managing ARFID, both for themselves or as a parent of a child who does have ARFID?
Yeah. So I think the first thing that I want to talk about is like diagnosis. You 100%, just like you can with neurodivergence, self-diagnosis is 100% valid. As I said before, like a lot of health practitioners don't fully understand ARFID, and it can be really hard to find a pediatrician, psychologist that can diagnose. So it is really valid self-diagnosis. However, it can be helpful to get a diagnosis. For some people, it can be incredibly validating. For kids in school, it can be really helpful in terms of being able to advocate. And so like being able to say to the school, my child has ARFID, this is what will help. Often there's a lot more action that can take place and more accommodations that are typically made. So whatever your decision is, that's totally valid in terms of diagnosis or not. It is really important to work with people that will not pressure you into doing exposures. Sometimes this is just not right for people, and they need to just work on their nervous system support, work through that trauma, and work on nourishing their body with whatever it is that feels safest at the moment. If food exposures are going to happen, they have to be led by the person with ARFID. And
when you say food exposures, you're talking about exposing them to new, different foods,
different types. foods that are not considered, I guess, safe. Yeah, essentially, yeah. And so, so that is, I would say that is one of the key things, is that we do not pressure food exposures, and our goal is not food exposures. Like whenever I see clients, I'm not like, my goal is going to make you to try new foods. That is never, ever my goal.
Okay.
Because, do you have a question?
I was going to ask, can you elaborate? Why is that? Because, I mean, that would be my first thought, I suppose. It's like, okay, well, how do we how do we expand your repertoire of foods that are safe? I think would be a question many other
I
people
think
might
that's
think, right?
I think that's a really normal and genuine question. I think that the thing is that if you think about the trauma element and the baggage, like the shame that comes from eating differently, feeling different, and all of that, if we were then to just go on and be like, all right, you need to try broccoli, or you need to try, I don't know, this particular biscuit, or whatever it is, and that person either can't try it because it just does not feel safe for them, or tries it, doesn't like it, or tries it, gags, whatever, that can be incredibly overwhelming
And a setback.
and also amplify those feelings of shame, of difference, of not feeling good enough. So to me, the most important thing really is really validating their experience and unpacking, you know, unpacking that experience and unpacking that trauma and really allowing them to be themselves. Just like with neurodivergence, my goal would never be to change someone's neurodivergence or to be like, well, this is how you need to be this is how you need to fit in to be more neurotypical. It's the same with ARFID. We want to really validate their experience and help them to feel like, all right, these are the foods you can eat. These are the foods that feel good for you. And that is so valid. And it's okay to be in that place. We don't have to work on exposures if you're not ready. But however, if they come to me and they're like, I'm ready, I want to try some foods, can we unpack and talk about what might be some things that we could start with? Like, these might be the foods that I've been thinking about. What do you think? Like, whatever. Essentially, I also want I want it to come from them. I want them to have the autonomy.
Mm-hmm.
I don't want them to ever feel like I'm pressuring or telling them what they need to do. It's their own experience, their lived experience, and they actually know what is going to work best for them.
Yeah, we always say that, and much like all eating disorder recovery and eating disorder treatment, ARFID is no different. It should be done with you, not to you.
Yes, 100%. Yeah, yeah. And if they're ready and they want to, amazing, great. Lots of people aren't, and we just need to fuel their body with what feels safe and really unpack, the psychological side of things. Yeah, so a few other things. So as I mentioned briefly before, like, I use the Fed as best model. So simply eating anything is better than eating nothing. And so that's the way that I work with my clients. And to me, it's just so important that they're eating. Doesn't matter what it is. Yeah. And as I mentioned before, if there's nutritional gaps, we fill them in other ways. We don't fill them through food if it's not accessible. So I think I mentioned this a couple of times, but, really validating a person's experience. If they tell you they have ARFID, just believe them. Like, you can ask them questions around, like, what does that mean? How does that present for you? If you feel comfortable and they're open to sharing. But if someone tells you that they have an eating disorder, just believe them. Like, and validate their experience. It's not. I don't think it's that hard to do that. But
yeah,
but I
we know that. Yeah, I wish it wasn't the case, but yeah, we know. Yeah.
So also, if you are an adult or you have children that have ARFID, please make their safe foods and preferred foods available and accessible always. Again, if we put down a plate of foods that are not safe, they will choose not to eat. They will choose to starve themselves versus eating whatever that is if it does not feel safe. So please, please, please always make safe foods accessible. And also, avoid judgments around eating. Like, I think whether someone has ARFID or not, we need to just stop commenting on what people eat. Stop commenting on their bodies, their gender. Like, can we just stop? Like, full stop.
Yep. Hard agree.
Yeah. And then also another thing too, if you are a parent, I think it is really important to respect your child's autonomy. So letting them choose when they need to eat, where they need to eat, how much they eat. And, I think some people might struggle with that a little bit, but essentially, if we think about our own relationship with food and we think about, well, as an adult, if I am hungry, if I know my blood sugar is low or I'm not feeling quite right or haven't eaten for 4 hours, I know I need to eat. And so I will go to the pantry and I will pick something and I will eat it. But we don't let kids do this.
Yeah.
A lot of the time, we don't. We control, they have to eat at this time of day or whatever it is. Yeah,
it's almost like there's this impression that kids have no self-control.
Yeah.
And I think by making them question what they're eating kind of takes away their self-control.
Yeah. And also, kids are fairly intuitive. Obviously, interoception can come into this, yes, and difficulties with feeling those body cues. But if a child doesn't want to eat everything that's on their plate, we should be respectful of that, because if you if you're not wanting to eat everything, you're not necessarily going to eat everything. So why do we force our kids to finish their plate? You know what I mean? And from my perspective, if my child says to me, let's just say they've eaten 3/4 of their dinner and they said to me, I've had enough. I'm like, okay, no worries. And often, maybe half an hour later, they'll want to have something else. And that's fine with me. I'm never like, you didn't eat your dinner, so you shouldn't be having something else. It's like, well, if I was eating my dinner and I've had enough of that dinner, I'm also going to stop. But that doesn't mean I'm not going to be hungry again in half an hour or have a sensory need for something else, like something crunchy or something sweet or whatever it is. So
yeah, I was going to say it's exactly the kind of thing of, there are other ways to eat and use food that's not for hunger. It could be for satisfaction. It could be for joy.
For pleasure,
it could just
for
be
dopamine.
Yeah, because I feel like something sweet now. I'm going to have that. Yeah, rather than, oh, well, I'm not really hungry. But oftentimes that's not the reason you're eating something.
Yes.
Because if I'm hungry, if I'm really hungry and I've got a bag of chips versus a full plate of food, I'm probably, if I'm really hungry, I'm like, well, I'm going to have the full plate of food because that's what's going to make me full right now. And I'll get the chips later.
Yeah.
When I'm a little bit peckish or feeling something salty again, it's one of those things. It's having that autonomy.
Exactly. That's right. And I think it's really important to mention too that I think that it's totally okay to eat for comfort. I think it's really important that we do sometimes, but I also know that diet culture tells us that that's a really naughty, bad thing.
Yeah.
It can actually be really, really good. And something else that I just wanted to touch on is that also, being a parent is really tough. When I say all this, there's absolutely no judgment from me around how you feed your kids or, whatever it is that you do around meal times. Everyone is different. And I really, truly believe that parents do the best they can. And it's really important that they should just do what is right for them and their family.
If you're feeding your kids, full stop, you're doing great.
Exactly. 100%. 100%. And
you're doing great.
Yeah, 100%. And also sometimes, we do things a certain way because because society tells us or diet culture tells us or our parents tell us. And so we're kind of conditioned to believe things about food and eating. And so we do it that way. And that feels like normal for us. But sometimes when we question that, we will then see how it actually doesn't work for us or for our family. And questioning that can be really powerful because then you can go, well, actually, I've realized that this isn't working for me. It's causing distress or whatever it is. What would work for my family? And if you can figure that out, it really makes the world of difference in terms of feeding yourself and your family and your kids. So a lot of parents and families that I see that have ARFID or feeding differences that are neurodivergent, they have really learnt to unpack what meal times need to look like for them. And for a lot of families, it's not just sitting at the table and having a conversation and having a merry old time, because that kind of environment actually does create stress and exacerbate trauma and things for some families.
Yeah, absolutely. And I was when I said earlier of if you're feeding your kids, that's great. I also want to just say, because of course now I'm hyperfixating on it, is if you are unable to because of like poverty reasons, you're still doing great. Just so you know,
100%. Yeah.
I wanted to put that out there as well, because I think there's this whole thing of all of these ridiculous expectations that get put on parents that they have to feed their kids a certain way in a certain style. There has to be like good whole foods, nutritious, but not too much, but not too little, all that kind of stuff. And there's all of these expectations just have absolutely zero nuance to it. And there's no, like, there are people who might not be able to, who rely on going to school for their meals, and that's the only food that they can guarantee in a day. There are parents who have to work multiple jobs so that they can't be home to sit and care for what and provide and cook for their kids. Sometimes they just have to be like, stuff is in the freezer,
Heat it up
yourselves, heat it up, please, because that's all I have for you right now. There is nothing wrong with that. Fed is best as you can. And I, like, again, what you were saying, like, we should just stop talking about and commenting on what people eat.
100%.
Because you have absolutely no idea what that person is going through, what their situation is, all that kind of stuff. It really grinds my gears.
Yeah.
And I mean, there have been times when I've like, and it comes from unlearning. Like, there have been times when I've said, I've thought comments. I'm like, okay, what actual facts do you have to base that on? And then like unlearn. Like, that's how it starts. Questioning the narrative that you've been taught this whole time. And if you have thoughts that seem like you're questioning something, that's fine, but don't say them out loud.
I think also, we don't know what we don't know. We do. I genuinely believe we do the best that we can. When we know better, we have the chance to do better. But when we don't know what we don't know, so to sort of finish that kind of question that we had was another thing that's really important, just making accommodations so that the eating environment does feel safe. So I touched on that very mildly before, but essentially for some people that might actually look like eating with distractions. So reading a book, watching TV.
I can't eat without distractions. I have to be doing something.
And for a lot of people that may be because when we're focused on our food, that brings up anxiety or it brings up previous trauma or whatever it is. So it's really important that we allow ourselves to do whatever it is that creates that safety, essentially.
Yeah. It reminds me of eating disorder treatment, if I'm honest, because it's just this hyperfixation on the food. And if you're having these experiences of anxiety where all the focus is on the food, you feel like everyone's watching you, then that's not conducive to a happy, relaxed food environment.
No. Totally. It's the same with mindful eating. And I know some people love mindful eating and that works really well. Great. For a lot of neurodivergent people, mindful eating is not accessible. It's not good for the body or for them. And it has the opposite effect. So it causes distress and anxiety. So if it doesn't work for you, if you've been trying to do it and it doesn't work for you, like, it's totally okay to acknowledge that it doesn't work and to not do it. And then the last thing I wanted to say with regards to ARFID and just support is getting to know sensory preferences. So whether it's for yourself or for your child, that involves not only the food that we eat, but also the environment as well.
Yeah, absolutely. Making sure if they prefer things to be loud and distracting, then great. If they need things to be quiet, then that's great. But doing other things, completely. It's not just about the food that they're eating, it's the environment in which they're eating in.
Exactly. Yep. And then with regards to food, like, if they need crunchy food to be regulated, give that crunchy food. If it's soft food or like salty food or sour food or whatever, like that also, we've also got to realize that, those foods, if that's the sensory preference, those foods help to maintain the nervous system and keep the nervous system feeling calm and happy. Just like it's the same as like other forms of regulation. Some people need deep pressure, some people need to be moving their body all the time. So it's the same with food. And some people also need to be moving their body all the time when they're eating, and that's also super valid too.
Yeah, this idea of like, oh, stop eating on the go. It's just like some people, A, may not have that choice.
Yeah.
B, some people that's pleasurable for them.
Yeah. Yep. Whatever
Or just a
gets it in,
preference.
you know,
Yeah,
whatever gets it in.
exactly.
Like, I'd rather someone eat on the go than not eat again. Like,
Exactly. 100%. I think, and we've touched on it, and it's the last thing that I kind of will say to wrap it up. In terms of how you can support someone with ARFID, there are going to be mistakes that we make. There's always, whenever you're supporting someone with any kind of eating disorder, there are going to be mistakes that you make. And exactly what you said, actually, if I may quote Maya Angelou, it's do the best you can until you know better. Then when you know better, do better.
yes.
So, and I think that, I mean, it goes in terms of life, but especially in terms of eating disorder recovery, I would say there are going to be mistakes. There are going to be things that you learn, but it's how you use that knowledge once you do know, and being proactive into how you can help. And also when someone says, ask those people how they can best support you. And when they tell you, do those things.
Yes.
That's even better.
Totally. And lived experience is so valid. Like, learn from people that have that lived experience.
Yeah, absolutely. Oh, this has been really, really informative. I've learned so much. So thank you. It's been really, really good. And I'm sure that everyone else listening to this could probably also has learned a lot too. I guess the last question I want to ask is something that we always ask people is, especially for those with lived experience, what does recovered look like to you now as someone who's been through an eating disorder, or recovery maintenance, whatever that definition is for you, and what does that look like for you?
Yeah, so I would consider myself recovered. In saying that, though, I do still get those anxiety thoughts. And I do see a social worker semi-regularly to support me through that, so that if stuff comes up, I can just work through it. And I find that incredibly, incredibly helpful. It's been actually so incredibly healing and validating seeing someone else that's also been through an eating disorder and just gets it. I've had no one really validate it in that way before, which has been so powerful, and I would say really has helped me to get to where I am. So in terms of like where I'm at, I think I just really understand and acknowledge like my history now, and also have so much more compassion for myself, so that if those thoughts come up, like negative thoughts, then I'm able to kind of check in with myself. I don't restrict food anymore, and in fact, since sort of working with this social worker, it's been very, very helpful for me in terms of reducing my health anxiety around for myself, but also for my children. That's something that was massive for me.
Yeah.
And also helped me to really find joy in eating and food again, and not feeling a sense of shame or guilt, and really just embracing my own sensory preferences, like when it comes to food and eating, which is a huge part of my neurodivergence. And I've just really loved being able to like bring in foods which I cut out because, I was told by society that they were quote unquote unhealthy.
Mine has been mayo.
Yeah.
I've never realized how nice mayo is.
I love mayo.
I never touched it. I thought I didn't like it because, I mean, first of all, it looks kind of gross, but I mean, it tastes amazing.
Yes. I love mayo. Yeah. Yeah, totally.
That honestly has been only in the last 5 years or so that I've actually been like, if I would normally say no mayo because I don't like it. But then I realized that I loved aioli. I'm like, aioli is just like garlic mayo.
Yeah.
And as soon as I realized that, I was like, oh my God, game changer.
Yes. I really relate to that. I feel like there was a lot of things that I would say, oh, I don't like that, because I had it in my head that it wasn't quote unquote good for you or healthy. Or allowed. Yeah, exactly. And so it's been like such a joy to actually go, oh, I loved this as a kid. And then I just stopped eating it. I'm going to have it again. And sometimes it hits the spot and it's like, this is amazing. And other times it's like, yeah, not that interested, you know.
I
Yeah.
remember I was making fairy bread for my niece's birthday, and I'm like, oh my God, I can't remember the last time I had fairy bread. So I ate some. I'm like, this tastes way better when you're a kid, but it still tastes great.
Yeah. Yeah, totally.
It's one of those things where it's one of those one true loves when that just it gets reignited once you have it
Yeah,
again.
totally. Like I loved what were they called? Chocolate crackles.
Yes. Oh my God. They're great. They're delicious and they're perfect.
Yeah,
No changes
exactly.
necessary.
Yeah, totally agree. Yeah, yeah, I love them. Maybe I'll have to make some. I haven't made them for a long, long time.
Yeah,
Um,
I'm gonna have to make some too.
yeah, yeah. But yeah, so I'm like super happy with where I'm at with things, and I feel like my I guess to kind of like do a full circle on this conversation, like just learning about my neurodivergence, how it was linked to my like eating disorder and everything has really helped me to just find peace within myself and really find that compassion and understanding for everything that's happened in my life. And so now it's allowed me to be able to share this stuff with people and tell my story, but also be able to use that, all of that history to support people. And my work, I'm just so incredibly passionate about my work, and really proud of, as well, of how like far I've come with my business and how well it's doing now. So it's all a part of, you know, my history and everything. So it's really exciting. Exciting things are coming as well.
I always get really smiley whenever I ask these questions when I hear people talk about things that they're really passionate about because it's infectious, and
Yes.
there's nothing better than seeing someone talk about things that they love and that they're passionate about.
Mm.
And I think your work is so important, and I'm so glad to hear how successful it's becoming. And how successful it is and becoming even more so,
Mm.
because there needs to be more talk about this. And I think the more people we can help, the better our society will be in general.
Totally.
And I think also the people who work with you are clearly getting a lot of benefit out of it because you're sharing your lived experience
Mm.
and you're not just sharing it, but you're reflecting on it and using that as a really empathetic tool to help other people go through it as well, which I think is really, really powerful, which is
Mm.
why I'm a massive advocate, surprise, surprise, for lived experience, people with lived experience working with people with eating disorders. It's
Yes.
so important.
It's so important. Yeah.
Mm. Uh, Again, thank you so, so much for this chat. It has been really informative. And yeah, I feel like, yes, this has been a very informative episode, but I'm sure there's still so much more to scratch the surface. I'm so looking forward to more research coming out about it because
Mm.
it's very much under researched, although things are in the pipeline now based
Yeah.
on the chats I had at ANZ AED
Yes.
with this year, and that there's been a little bit more of a focus on that, especially with the more focus on neurodivergence as a sort of comorbidity.
Mm.
And yeah, the future looks good in terms of resources becoming available
Yeah.
and the focus being put on ARFID as its own separate specialty, if that makes sense.
Yeah, definitely. Yeah. Yeah, I feel like we're getting there. It's starting, awareness is happening. We'll get there eventually. It's just, I guess, going to take time. Yeah.
Yeah, exactly.
Yeah.
Now, your Instagram is full of extremely informative little digestible bits of information. I highly recommend everyone go follow you. Where can people find you?
Yeah, so my Instagram handle is Margos, MARGOS _ whole body nutrition. I also have a website, which is wholebodynutrition.com.au. I have Facebook as well if Instagram's not your jam. And I think my Instagram is just whole body nutrition. Maybe we'll have it in the show notes.
It definitely will be.
Yeah, yeah. And I did also want to say that I do have a few free resources on my website as well, and a couple of paid. But yeah, there's lots of like really good free content on that and my Instagram as well. Yeah.
Awesome. Go and support Margo. She is amazing. If you need help reach out to her as well, because I'm sure her services are outstanding. Well, I already know that they're outstanding.
Thank you. Thank you.
And yeah, I think there's so much information on your page that I think if anyone wants to know more, head straight there, because there are, you'll learn a lot, just like I have.
Yes, there's a lot. I spend a lot of time creating content, but I love it. I genuinely love it.
Good. Oh, you can tell.
Yeah.
Put it that way.
Yeah, good.
And the advertising nerd in me is like, branding on point, all consistent, love it, style guide out of 10.
Oh, that's so good to hear, because I do it all myself. So thank you. That's awesome.
It's very distinctive, put it that way. I always know your posts when they come up.
Yeah.
So already
Cool.
branding tick.
Awesome.
That's all for today's podcast. Thank you so much for listening. Don't forget to hit that subscribe button so you don't miss an episode. And if you like what you hear, please consider giving us a 5-star review on Spotify or Apple Podcasts. You can follow us on YouTube and Instagram at pavewithgoldpod. Send us an email at pavewithgoldpod@gmail.com, or visit our website, pavewithgoldpodcast.com. All of those links will be in the show notes, along with extra resources. As long as where you can find Margo, go there, it's all there. Until next time, stay safe, and we'll talk to you again soon. Bye.
Bye. Thank you so much.
Thank you. This podcast is general in nature and has not taken your personal circumstances or medical history into account. We are here to share our own experiences and the things that we have found helpful throughout our own personal recovery journeys. Please remember that each person's journey and circumstances are different, and not all of the information contained in this podcast may be relatable to you. It's important you consult your own GP or recovery team to seek out tailored advice before making any important decisions relating to your own health and recovery process. If you have found any of the content in this episode distressing, please contact your care team or a medical professional. If you or someone you know is in crisis and needs help now, please contact emergency services in your region immediately.